Thank you, Thorsten. Well, this is a very quick look through alignment, balance, and other factors in total knee replacement. So Sam McDessie and others in Sydney have defined this coronal plane alignment of the knee, where you measure the lateral distal femoral angle and the medial proximal tibial angle, and then if you add the two, you get the joint line obliquity, and if you subtract the two, you get the anatomic hip, knee, ankle axis. And they've created this grid with apex distal deformities, neutral deformities, and then varus, neutral, and valgus deformities. That's a useful way of classifying knees, and this has been validated on normal knees and into those categories, and also validated on arthritic knees, and the incidence in both those groups is similar, justifying the system. There's really only the 6 types, but the other 3 types added in the matrix for a visual guide, and they're important because if you move a patient from type 1 to type 9, it creates problems for the patient. So are these important? If you look at the type 1, the incidence in Australia is 19%. In Belgium, it's 26%. If we skip forward to the Asian populations, Japan and India, it's actually 58%. So there's supposed to be a map behind that of the world. But so there's difference in these deformities in different populations. And there's also gender differences, with females more likely to be valgus and males more likely to be varus. But does it matter? What about the outcomes? Well, if we look at patients who have type 5, so no varus or valgus and no joint line obliquity, then it doesn't matter if you use kinematic alignment or mechanical alignment, you'll get the same result. So the forgotten joint score in both of these, comparing mechanical and kinematic, were the same. However, if you look at type 1, which is very common in India, with the varus knees, if you just use mechanical alignment, they show that you have a lower 2-year forgotten joint score compared to if you use kinematic alignment. So why is this? Well, we're doing some work in the biomechanics laboratory looking at the lateral condyle lengthening and the effect on the patellofemoral joint. So if you don't do an apex distal cut, you'll be lengthening the lateral femoral condyle, which tightens all of these structures on the lateral side of the knee. And when we do biomechanical testing and we measure the pressures in the patella, we see that in the yellow here, where there's a little bit of lengthening of lateral condyle, you increase the patella pressure. In the red, where you have a lot of lengthening, you increase the patella pressure. So that may be the reason. But this is just looking at the coronal plane. I'll just skip forward because I wanted to make the point that the major forces across the knee are actually in the sagittal plane. So the axial forces are in black there. The blue forces are the sagittal forces. And when you look at other activities, and you look at these 2 charts up here, so this is the coronal plane, this is the sagittal plane. The forces vary in the sagittal plane, so the sagittal stability of the knee is actually critical, and that's completely missed with a coronal analysis of the knee. And so sagittal instability will give you things like difficulty on stairs, and you can do a Lockman's test and see the tibia moving forwards and backwards in the sagittal direction, which is much more important for knee function. So the design of the implant becomes important for that, because these forces are not directed axially, but they're directed anteriorly as well. So if you have a round-on flat, you'll have these forces that create a shear force, which creates the instability. And so that's when the ligament stability is important if you've got round-on flat, but if you have some laxity in the ligaments, you'll still have stability depending on your implant design. And so people talk about conformity and conformity ratios, and I just put this up as an example with an analogy for hips. If you have a 36 millimeter cup and a 36 millimeter head, you'll have a fully congruent bearing, it'll be stable. But if you put a smaller head in a cup, you'll have instability, and a lot of these different designs have inbuilt instability in the designs. So I would just say successful combination of alignment, balance and surgical technique is important, but implant design is also important, and don't forget the sagittal plane. Thank you.